Stay tuned as On Call Television answers your questions about asthma. Funding for On Call Television is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call Television as it continues to open doors for important medical information. And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding is provided by Dakota Care, the Brookings Health System, Dr. Mark Bubak with Dakota Allergy and Asthma, Dakota Dermatology, Aberdeen Asthma and Allergy, the Orthopedic Institute, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation. Asthma is a chronic lung disease that inflames and narrows the airways. It causes periods of wheezing, chest tightness, and coughing. In the United States, more than 25 million people are known to have asthma. It's the breath of life, as the doctors are on call tonight.
I was looking for a breath of life, for a little touch of heavenly light, but all the choirs in my head said no.
Hello and welcome to On Call Television. Tonight, asthma is the subject of our discussions. It's interesting to note that the word spirit comes from the Latin spiritus, which in turn means breath. In fact, the Jewish essence for God refers to the Spirit of God that breathes life into all beings. It is the breath of the Almighty that has given life. And at the end of life, we expire. We breathe out, and the Spirit leaves us. So it is that we must breathe to stay alive, and when that breathing is compromised, we cannot stay alive. In fact, every year in this country, over 3,300 people die from asthma. That means that on average, 9 people die every day because of asthma, and most of the deaths could have been prevented if the disease had been properly controlled or cared for. 1/4 of all emergency room visits over the course of a year, are asthma emergencies. Asthma is the country's most common and costly disease. Tonight we have 2 very special guests and friends with us to help answer the questions you may have about asthma. Let's meet our guests. So first we have Dr. Mark Bubak. Dr. Bubak, people say Bubak other parts of the country, but it's Bubak, is it not?
That'd be the Czech way.
That's the Czechish way. And you are living now in what town?
I'm in Sioux Falls, South Dakota.
And practicing with your clinic called?
Dakota Allergy and Asthma.
And where did you grow up?
I grew up here in South Dakota and did my medical school in South Dakota and then my medicine and allergy training at the Mayo Clinic.
And then you came back to South Dakota, worked in Sioux Falls for a period of time, and then Mayo said, come back. And
worked at Mayo again, and I really like Sioux Falls, and I just love South Dakota, so this is the place for me.
And you're an allergist. But allergists throughout the country are also people who specialize in asthma.
Our specialty deals with asthma, allergies, and immunology type problems, and we see people with asthma at any age.
All right. And we have, with Dr. Bubak, we have Dr. Hericks, who is a pulmonologist, different than an allergist. A pulmonologist is a specialist in lung disease and a variety of different lung diseases. Anthony Hericks, Dio from Sioux Falls. Where are you from originally, Tony?
I grew up in Gettysburg, South Dakota. I was an undergrad at SDSU, Did my medical school and some of my training in Des Moines, and then Kansas City for Pulmonary Critical Care Fellowship, and now back in Sioux Falls.
So critical care too as well. Do you do any critical care medicine now?
Yes, we do rotations through the ICU on a weekly basis between my group and a few others at Avera. So.
And then you're also board certified in sleep.
Yes.
In fact, we've had you twice on the show for sleep disorders and sleep conditions.
Yep, this is the third time here.
Yeah,
so.
this is great, and I think Mark's a repeater as well.
Mm-hmm.
What's the difference between a pulmonologist who treats asthma and an allergist asthma specialist?
In my opinion, I guess it's that there's what I call intrinsic asthma, which may not have an allergic component to it, and then there's atopic asthma, from what I've been told, where there's more of an allergy component. And sometimes the more intrinsic asthma, there's nothing to do other than treat symptoms, and sometimes in the more atopic forms of asthma, maybe treating the allergies and other things like that could be beneficial. In the more difficult cases of allergy-induced asthma, actually I refer most of my patients to Dr. Bubak for a second opinion.
For that acute allergic component.
Actually, there's more of a difference between the specialties, and you're lucky you get to specialize in one area. We don't get an organ. As an allergist.
You don't have an organ.
Yeah, it's the whole immune system and things, and so there are a lot of masqueraders in asthma, and a pulmonologist is an expert in a lot of these other disorders as well.
Let's talk about the masqueraders, and then we'll get right into asthma. But what we need to do is we need to ask you to call in your questions. Do you or someone you know have asthma? Have you ever been around someone when they suddenly began having an asthma attack? Then you may know just how scary it can be, especially when it is a friend or a family member or a child. Your questions are so important about asthma. Don't hesitate. Please call in your questions or comments about asthma. Tonight's show is your show. Please call 1-888-376-6225. That's 1-888-376-6225. Or you can submit them at oncalltelevision.com and click on the questions button. It's your calls that make it. And if you call early, we'll get those questions. Sometimes we don't get to them when there's so many. Let's talk about what is asthma, and then what are the charaders. What is the definition of asthma?
I always like to think of it as a reversible condition where a person coughs, they might wheeze, tight chest, short of breath. It comes and goes by definition. Certain medicines like albuterol help it. And in doctor lingo, there's inflammation or swelling of the bronchial tubes. There's a lot of mucus that's made, and then the muscles around the pipes, the bronchial tubes, squeeze. So that's asthma.
It's the muscles that squeeze that can be reversed that really is that key point of differentiating asthma from what are the other obstructive lung disease?
It's the muscles plus the swelling. Both can be reversed.
Okay.
But
It's inflammation, just like I tell patients, it's like if you sprain your ankle, you get this acute thing that causes a lot of edema and the ankle becomes tense. That's the same thing that happens with the airway. So it limits the amount of blood flow through the ankle when it's swollen, and limits the amount of the airflow through the airways and can cause some obstruction.
So differentiate between asthma, which is reversible, chronic bronchitis, which is more mucus, and emphysema, which tell me how to differentiate the three.
Well, if we were to take all three of our coffee cups here and we were to put them into the center and they would overlap a little bit in the corners, there's a Venn diagram published out there is what it's called. And in one quadrant you have emphysema, which is dilated airways, dilated air sacs because of destruction from tobacco smoke exposure, environmental occupational exposures. On the other side of the coin you have the chronic bronchitis, which is those same exposures can cause swelling of the airways that's not reversible. It's a completely different kind of inflammation. There's mucus gland hyperproduction and enlargement. And then on the last little circle you have asthma, which is a reversible, reactive airways disease. The problem is, as you brought up about masqueraders, is right in the center of that circle is a little triangle which sometimes is very difficult to differentiate. Is this asthmatic bronchitis? Is this emphysema? Is this chronic asthma that's been uncontrolled and you've had remodeling of the airways so they don't react and don't go back to normal like they should? Or is it truly asthma, which is reversible airways disease? And so that's sometimes very hard to differentiate. I get so many journals and emails from different people with educational material, and I recently saw an email that talked about how asthma is one of the, I think it was either one of the most undiagnosed conditions out there because of these masqueraders. And then on the other hand, I see a lot of people who've had breathing problems as a kid or as an adult, and nothing against the primary care doctors, but they'll label them as asthma and treat them as asthma when it may be something completely different. So,
yeah. Would you add, I mean, that's still complex. I mean, we talked about swelling, we talked about inflammatory deals. Those are doctor words. Can we put them into 3 categories and say it in a real simple way? Mark, I'll challenge it.
Well, I guess the people with chronic bronchitis, the walls swell and ooze the mucus, and so they cough up a lot of sputum. And then the emphysema people, the air sacs, or where we get our oxygen, have been destroyed, so we just can't breathe. And the asthmatics, they've got swelling and they can't breathe, they cough, they wheeze. A lot of the symptoms end up being the same.
Now, the asthmatics who have that reversible and twitchy muscles and so on and so forth, but swelling too, that's our attention tonight. We see it mostly in the young people. You see it oftentimes in very young people. When does it start?
In my opinion, I see all kinds of people, and I don't really completely understand this, but there are children that get asthma and may be quiet as they get older and quote unquote grow out of it. And then there may be those that have persistent asthma through their entire life and may be quiet in adolescence and young adulthood and come back in adulthood. And for some reason, when I see some 80 and 90-year-old patients with breathing problems and do pulmonary function studies, they look like they have asthma. And I don't know if it's a viral-induced trigger that sends them into that, or, but I don't see a lot of the pediatric population, but I have to go back and ask those questions. Well, did you have breathing problems, or were you diagnosed with asthma as a child? Whereas Dr. Bubak sees the whole conundrum. So.
A lot of people talk about reversibility with adrenaline or albuterol, or these, these puffers that people have. The old one was over-the-counter was
Primatene mist.
Primatene mist. But if you could reverse it, if you could get better with that, does it say for sure that that's asthma?
It's a helpful hint.
It's certainly a clue.
Yeah. Yep.
And if there's a lot of mucus, you think it's bronchitis, or there's chronic bronchitis, or low-grade infection that could be part of it. And when they're hyperextended, flattened diaphragms on chest x-ray, and they can't get the air out and it doesn't reverse, that's emphysema. And they've had a lifetime of smoking. That's the picture of emphysema.
Wish it was that easy, though. I mean, I see all kinds of patients that have hyperexpanded x-rays and you don't know. I mean, in all truth, asthma should be reversible. And if you look at people who do breathing tests, there should, for a lot of people, be periods of time where they're completely asymptomatic from disease.
Without symptoms.
And you bring them in and we have them do breathing tests, and guess what happens? They're normal. And so when I read pulmonary function for people, or the breathing test that you look for COPD or asthma or bronchitis, I always put in there, if the scenario is right, normal pulmonary function, do not rule out asthma if they're not exacerbated. So.
Right. Sometimes they have you inhale irritants to see if it brings on asthma. Tell us about that.
Provocholine or a methacholine challenge, it's just like you said, it's an irritant, breathe in, and it can provoke you to have an asthma attack. There's a certain amount that if you give a big dose, everybody will tighten up, and so it's very controlled.
So these 3 really are the obstructive lung disease, where you can't get the air out. People can breathe in fine, but they can't get the air out, and it's this long breathe out, long wheeze, 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 wheeze. All 3 of those cause that. There's these other things that can cause breathing problems, but it's not obstructive. Things like pulmonary fibrosis and scarring of the lungs and
heart failure, or problems where your vocal cords, your trachea is narrowed.
What else?
I'm going to pick on our cardiology friends and agree with him, because not all wheezing is asthma, number one. And a lot of times at the heart hospital, when we see people before their bypass, they'll get pulmonary function studies, and they'll have a reactive airways disease process or asthma type process. Is it truly an undiagnosed asthma, or is it more a reactive airways disease because of cardiac complications? And it's hard to say.
Yeah, people with a little heart failure will sometimes get a little asthma from the failure, and then they'll wheeze. I mean, they'll have the classic cardiac asthma.
You give them a little bit of albuterol and it gets a little better. So
It's, in other words, it's hard to do this job. I mean, sometimes it's not clear as a bell, is it?
But it's fun.
yeah.
And you can be very helpful, get it figured out, and people get better. That's what you should expect with asthma, is that you should have a program that works.
Yeah, but people die from it. Now, why do they die from it? If we have a program that works, why do people die from it?
Asthma can be all different severities. It can be from the mild intermittent asthma, where maybe you get a wheeze once or twice a year, this time of year when the molds and the grain dust and everything are floating around. And you can have the severe persistent asthmatic, where you try everything possible and they just try to get through their day without having a bad asthma attack. And if they get a bad enough asthma attack, as we talked about, that obstruction, the airways open when you take a deep breath, and they close, and there's something sitting there, mucus and inflammation. It kind of traps air in the chest, and it's like blowing up a balloon but never letting it out. Either the lungs pop, or it puts so much pressure on the chest that they end up with cardiac failure. It's called, it just slipped my mind.
Tamponade.
Yeah, tamponade. But,
Yeah. So I mean,
explosive asthma or near fatal asthma. Or
I think that there's the different severities, and unfortunately, not all folks with asthma stick to the program. There's a lot of reasons for that. If you don't take your controller every day, it generally doesn't work. And if you have bad asthma, you have to stick with those. You might not have enough money to pay for it. You may just forget to do it and not want to. You might have side effects from it, and then you catch a real bad cold on top of it. And so there's all those scenarios.
some people are very poor perceivers of their symptoms. They don't know that they're in trouble until they're in trouble, and next thing you know, they're in the ER and
near death,
really bad. So.
I mean, it can be very fast.
I remember one lady that I used to take care of in fellowship, and the problem is one of the other mimickers is something called vocal cord dysfunction. So what happens is that you get anxious, nervous, excited, angry, and the vocal cords, instead of being open so air can go in and out of them, they spasm. That causes wheezing and what we call stridor, and sometimes it can mimic bad asthma. The problem is her pulmonary function studies showed she had asthma. And we treated her like bad asthma, but there'd be times she'd come in the emergency department. We put a breathing tube through the vocal cords, which got rid of the obstruction. She was completely gone.
It was vocal cord
dysfunction, let's call it.
Yeah, stridor, meaning that you can get the air out, you can't get the air in, whereas asthma, you can't get the air out. Real quickly, because we're almost out of time, why is it that asthma, you can get the air in, but you can't get the air out? Good question. Physiology.
Yeah. To me, it's the airways. When we breathe out, the airways and the air sacs are pulled open. When we breathe in, everything's compressed a little bit. And if there's something, it'd be no different than the water pipes in your house. If you had an obstruction there and you could pull them open, then you could relieve the obstruction. But if they collapse, then the water can't go through there. Yeah. It's the same with air. So.
I think that's a good answer. Well, the first step in diagnosing asthma or other respiratory disorders is the pulmonary functions test. You breathe in, you breathe out, and the machine measures your lung capacity. How much oxygen is passing through, how much air your lungs are taking in.
Now, big deep breath in, suck it in. Whoa! Push, 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 push. Keep going, keep going, keep going. You're almost there, almost there. Deep breath in now, Jean. Good job.
It's a way for us to actually measure how much volume a person's lungs can hold. It also gives us an idea of the elasticity of their lungs, or if there is some kind of obstruction there. We see that in patients that have asthma. COPD is a common reason that people would come and get pulmonary function tests. Bronchiectasis, a variety of different, respiratory illnesses that compromise someone's breathing. Typically what we do is we do a baseline screening where you do 3 breaths, And then if the numbers looked abnormal or it looked like they might have asthma or COPD, if the values would indicate to us that there may be a problem, we would administer a breathing treatment or a nebulizer treatment with a bronchodilator and wait a period of 15 to 20 minutes for that medication to take effect. And then we would repeat the same exact test and then compare the before and the after values, and that would let us know if there was any improvement after the medication was administered. So in your lungs, think of your lungs kind of like balloons, but they're not really, they're more like big sponges. And inside those sponges is this bronchial tree, and these are what I refer to your airways. This is what the inside looks like. This is the right and the left lung. And these are hollow tubes, just like you see here. The air moves in and out. These kind of stringy looking things on the outside here are the muscles that wrap around those airways that I was talking about. In a normal airway, you see it's nice and open, and these aren't squeezed down. In an asthmatic, you have an excess of mucus, but if you have an asthmatic component, you have a lot more mucus that builds up in your airways, and then these muscles that wrap around, they get tighter and tighter like a rubber band around your airway. And as you can see, there's a big difference between this opening and this opening. So this is a normal airway. These little fingers here are what we call cilia, and that helps move that mucus up and out of your lungs. When you have chronic inflammation, as in asthma, and irritation to those airways, this lining gets swollen and inflamed, the muscles get tight, you have more mucus, makes it really hard to breathe. So if someone's in an asthma attack, what happens is this airway gets really, really small because it's all inflamed and aggravated.
Well, thank you, Respiratory Therapy Department, for the Brookings Health System and sharing that, and Janie, and indicating how you test for it. There's a lot of pulmonary function testing that we can show, oftentimes reversibility. So tell us about this. What is this?
This is a peak flow meter, and a person, if you're motivated to want to do measurement at home, you can actually have something like this prescribed. And it gives you some numbers as to how well your flow is. These are much less expensive to have than a spirometer. And if you're motivated, you blow hard, you can actually see that as you're getting sick that your numbers start going down, and give an early warning that maybe an intervention has to happen with your asthma action plan.
Right, I mean, well, show us how it goes. Let's see you blow now.
Normally you stand up and you take a big blast.
And you see how high it goes, and that's your number.
Yep.
And you do 3 of those.
3 of them, and whatever the best is the peak flow.
All right, so that's your peak flow, and if you've got asthma, I'm feeling pretty good. There's my peak flow. I know I'm doing good. You know, I don't know if I'm feeling good or not. I'm in trouble. Oh, it's lower.
And you could do that.
And you can monitor when. So tell me how I use those numbers. So when they get too low or they start to drop? Typically
you have ranges, and it's like a stop sign or stop light. Green zone's good, yellow, things are coming down, and then red is danger, things are bad. And so if you have a motivated patient or family and who will actually do it, this can be helpful. One of the problems I find is that the more things I give patients to do, the less of them that they actually do. Right. And so, adherence is so important in asthma, and so you have to be careful. This is especially nice for the folks that who can't tell how good they're doing, and that's about half of patients can't. And sometimes you get them a little bit more sensing when their lungs aren't doing well by this.
Right. Asthma is a outpatient treatable disease, meaning if you treat it right, you adhere to the program, you do what we recommend for the most part, you can keep a lot of people out of trouble. So you can actually send them home with a sheet of paper and a set of numbers based off their pulmonary function and how they do and based on their history. And you can give them all the tools so they know that if they get into trouble, they do A. If they're doing fine, they do A. If They get into trouble, they do B. If they start getting into trouble
They
near
add C.
they add C and they call their doctor. And so an asthma action plan, and this is one of the best tools you can give your patient.
The problem is compliance on this. That is the issue. If they're well motivated, as you said, Mark, and that's it. It clues you into, oh, I'm getting into trouble. 50% of the people can't tell they're getting into trouble. So that's one good measurement to keep you as an outpatient, not going to the emergency room, not putting yourself at risk.
It helps tell you just where you're at on this spectrum of mild to quite bad blockage. You can see the difference in how wide across the caliber of the pipe is.
So let's take a close-up, get a little closer to it than that. This, on this side, is the normal.
This would be normal, nice and wide pathway. The muscles aren't squeezing. We're not making lots of mucus. You start getting worse, the tube gets smaller, we're having more spasm, lots more mucus, and it ends up being just a tiny straw that the person's breathing into. And your peak flow goes from, say, 700 over here to maybe it's 400, 200.
And you're in trouble.
Yes.
Just imagine how much water comes out of a fire hose versus comes out of a straw when you shoot it out. The amount of flow that can go through a larger diameter tube. And so when you blow and you blow really hard, like Dr. Bubak demonstrated, it takes those small airways and closes them down even more. And that's where your peak flow is limited.
So my lovely wife brought out an example of what you can do if you're blowing on into a normal scenario. You can blow it up. If you've got inflammation, it doesn't work. And so thank you, my dear, and talk about gooey. She worked hard to make this much mucus in which to block that. So anyway, that's a good. We're talking causes of asthma, and I want to talk about triggers before we go to questions. And we've got great questions. Thank you. Triggers that will bring on asthma. What are they? What are common triggers?
Well, as an allergist, I always say allergies. So, and I think of two types of exposures. One's chronic. You're exposed to the cat in your house or the dust mites or a long mold season, and that's chronic. It's making that swelling day in and day out, and you just think that's normal. And then there's the acute type where you don't have a cat and you go to your friend's house and all of a sudden, bam, it just gets you. Another trigger type of thing, viral infections. They're huge, especially in kids.
Right now, colds are flying around like crazy. I mean, this is the cold season.
Yeah.
This is how much I trust Dr. Bubak. My daughter had RSV as a child and had she didn't need to go on a ventilator.
What is RSV?
RSV is respiratory syncytial virus. It's a very common infection that happens to pediatrics. They produce large volumes of mucus from the nose and the airways, and it causes obstruction and fast breathing and wheezing. And some kids...
A bad cold in a kid.
Yeah, and sometimes they get sick enough that they'll end up having some airway reactivity or asthma-like symptoms afterwards. And she did for the longest time. Well, she's kind of grown out of it, now back into it, and I figured he was a good expert to send her to. So
here, you, the pulmonary asthma specialist, sent your child to this pulmonary.
You don't take care of your own kids.
Yeah.
No,
That's
you
one of the
really,
rules.
you really don't.
They don't listen to you at all.
Well, they don't.
I
do
know
they?
that. My son.
well, and the other thing is asthma is not anything you really want to mess with either. So if I blow it off as a father and say, what, toughen up, hit him on the back and tell him, go on, you'll be okay. He's not going to do that. He'll use kid gloves with him and do what's right for him. So.
Well, you have to watch out for other triggers like irritants such as cigarette smoke. I mean, that's another big thing.
Yeah.
And
Is that really? I mean, they talk about secondhand smoke. Is there scientific data to say that children who are raised in a household where they're smoking have more asthma, more breathing problem? What's the data?
That's true.
I mean,
everybody knows that.
Yeah, I mean, we've got scientific data,
Yeah.
solid data.
Yeah.
We have adults that have been exposed to secondhand smoke their life develop emphysema and lung cancer. And we know that anything that attacks a growing lung when you're young contribute to lung disease down the road. And that may be reactive airways disease, it may be COPD or emphysema or chronic bronchitis or lung cancer even.
So there are real triggers out there. Let's talk to Pierre. Is there a relationship between cough variant asthma and nasal polyps? Cough variant asthma. I know that some people cough so much that it irritates things so that the asthma comes on, and or nasal polyps.
There's a lot of folks with nasal polyps actually have asthma, and the third part is often the aspirin that triggers things off.
Aspirin will bring on polyps and asthma in some people.
Aspirin triad. And so if your version of asthma is more cough than the wheezy stuff, then that sure could happen.
Can 81 milligrams of aspirin do it?
Yes.
And how often is this? Not that often.
I don't know how frequent. I probably have 3 people in my clinic that I've been in Sioux Falls for 4 years that have what we call Samter's triad, or aspirin sensitivity, asthma, and nasal polyposis. And Dr. Bubak and I actually share a patient that's got that has had her nasal polyps removed multiple times to see if that would help control her asthma.
Did it?
I think it does periodically, but then because of all the irritants and allergens, and the polyps just come back over time.
And of course you avoid aspirin. How about Advil, Aleve, the other non-steroidals?
You have to avoid them.
Yep.
They are avoided. And that's called what triad?
Samter's triad, or the aspirin sensitivity triad.
George Samter or Fred Samter or somebody, yeah.
Above my pay grade.
From Brookings, how do asthma rates in the U.S. compare to other countries? Do you know if there's a difference? I know that there are very polluted areas in the world, certain parts of China, parts of Russia, and there is a significant amount of, from National Geographic, there's a significant amount of lung disease related to that air pollution, but I don't know any comparison data. Do you?
No.
The frequency of or prevalence of asthma varies markedly all over the world. And even within the United States, there are groups that have a lot higher problem. If you go to, say, the farmers have far less asthma than city dwellers. And so you can't even just say one country versus another. They're just...
Farmers have less asthma.
Right.
You'd think they have more air pollution or
No.
more dust exposure.
They have a lot more endotoxin around the waste products and things, and that helps distract our immune system away from being allergic and asthmatic. That's one of the hygiene hypotheses.
Yes, they've been exposed to more things, and therefore they don't have asthma as much. That's
Right.
funny. The clean air of the city and all that, whatever, they have more asthma. Do you agree?
Well, but they also say that people that live in the inner city maybe have more smog and more occupational environmental exposures that they may run into too.
So it may well be the clean air in the country and the smog in the city. Who knows? There's a fair amount of debate.
In Kansas City, we saw a prevalence of asthma in the African American population more than we did the Caucasian population. Some of that is one of the places they trained was at an inner city hospital. So we saw more African American population, but I can tell you asthma far outweighed in our asthma clinic that of the Caucasian.
I know that Hutterites have a familial higher risk of asthma. I mean, does it run in families? I mean, is asthma a familial thing?
Definitely. Yeah.
Okay, I've got a question. What is atelectasis?
Atelectasis is those air sacs at the end of the breathing tube. If you blow this balloon up like you did and it's full, the air sacs open, and when they close, they never completely go out. So if we were to blow up this balloon, see if I can do this. Okay, a little bit of air out, and the balloon stays open. What happens is we take another breath, it blows up. There are certain conditions, mucus, plugging from asthma, COPD, pneumonia, where those air sacs start losing the amount of air in them, and they just shrink. And pretty soon you have a collection of little air sacs that
are all
air.
collapsed.
Yep, all collapsed.
Collapsed air. And so when you listen on a stethoscope, it crackles and it looks like pneumonia.
Yep.
But it isn't pneumonia.
Right. It's just collapsed air sacs.
Collapsed air sacs. Rapid City, $7.50 in Europe for a rescue inhaler, $200 to $300 here. Why is this happening and how can we fix it? It kind of makes me mad.
There's a
This is a rescue inhaler.
Nope. There you go. There's one, yeah.
Rescue inhaler, albuterol. Ventolin.
Yep.
Okay. It's $200 to $300 here. Why is it cheap in Europe or Mexico or everywhere else in the world?
There are a lot of different price restraints that other countries put on drugs. Often the country will tell the companies what they can do. We have a free market system here, and the patient themselves usually isn't the one buying it. You know, there's an insurance company in the way, and they pay part, and so we as consumers don't see the whole thing. People probably wouldn't ever buy the stuff for $200 here if they knew it was $200. Instead, it's a $20 copay.
Yeah.
And as you know, with every drug, you could have, let's see, what else do we have here? We don't have any other short-acting, but there are four common short-acting medications that we can use. Zopanex, ProAir, Proventil, and Ventolin. Depending on your insurance company, your hospital, your insurance company, whoever, negotiates with the drug company what tier your drug is going to be. Tier 1 being the cheapest, Tier 3 being the most expensive. So you have Blue Cross Blue Shield, maybe it costs you $15. If you go over to Dakota Care, maybe Ventolin costs you $50. So it's all the free market system.
But it costs somebody $200 to $300 is what it does. And it used to be dirt cheap because the generics came out, but something's happened, particularly with inhalers. And we don't have a generic inexpensive steroid either. I mean, there's some problems there. I don't know what they are.
I don't remember exactly when, but it was probably sometime around 2006-ish that somebody got, the propellant in there was damaging the ozone. So that gave the drug companies, which was a generic drug, albuterol, they made it into a different propellant that was safer for the ozone, and then they could remarket the drug, repatent the drug, and so then it's been more expensive. So.
Yeah, well, that'll go away, I hope, but at the same time, you want your companies to be able to be profitable, and if other countries don't pay, then they'll not be profitable, and we won't have these drugs. So there's
it is hard to make generics because the devices that make the fine mist, everybody has their own one, and in order to get this down into your airways, you have to have just the right size particles. It's not like a pill, and so there's a lot more behind the scenes engineering things, but it's been done, and people need less expensive drugs. It would help adherence.
See that on the back of there? That's also patented. That's a drug counter, how many inhalations. So not only is this medicine that's in this device, but this exhalation or inhalation device is patented as well, so both of them are there. So you can't just say, well, I'm going to make albuterol. You got to figure out a way to give it to people too.
Yeah. That's another show. Is there an ethnicity group that's more prone to asthma? You suggested that it was worse in blacks.
Yeah, African Americans, and at least from my experience, seem to have a higher rate of asthma than do the Caucasian Americans. I don't know the statistics.
Yeah, and certainly my experience in Atlanta, boy, there was a lot of asthma in that group. Any others?
Actually, the Hutterites here in South Dakota, they have really a very high incidence.
Yeah, Rod Perry had done the research, and they're a homogeneous group. They're very close, and we can study them. Here's an email from Sioux Falls, where I currently take Avera and Singulair. If I lose a significant amount of weight, is there a chance I could reduce the amount of medication I use?
I think that's complicated, but if there's a potential. At a number of levels. There's how much of the breathing issue is the weight and the pressure, and then if you have if obese people make a lot more inflammatory mediators that might make things worse.
And I can tell you by taking cameras and going down and looking at people's lungs, called bronchoscopy, that the more tissue you have on the outside of the bones, the more tissue you have on the inside of the bones, and airway obstruction above the vocal cords can be a problem, and that's another reason for asthma. And some people that have obesity actually have collapsible airways. So when they breathe in, they open up, and when they breathe out, they collapse without...
Atelectasis.
Well, yeah. It's called, the technical term is bronchomalacia. So it's instead of taking a nice rigid tube like this, you make it a wet piece of paper, and when you exhale, it squeezes on it, and that limits airflow and can cause wheezing and mimic asthma as well. So weight loss is very important.
I would say that as well. The heavier person gets all sorts of problems, including when they go to bed at night, they have aspiration higher risks, and so they inhale some of the food in the night because they're heavier, and it pushes up, and the result is they have more inflamed airways. And the sleep apnea story.
It's been shown also in children that weight loss actually improves the asthmatics with their quality of life.
Let's start. Here's the question: What is your take on Max Air treatment for allergic asthma, and how effective? So let's go to this albuterol beta agonist, which is not Max Air, but
Max Air would be just a different bronchodilator
version of albuterol. Let's talk about beta agonists. Those are adrenaline-like drugs. There's short-acting adrenaline-like drugs, and there's fast and long-acting, 12-hour or even 24-hour now. Mm-hmm. What do they do, and what warning do we need to have about them?
The mechanism of action is that these relax those muscles that are squeezing, take it and it opens up. The Max Air works as well as the albuterol, all of them work about the same. And so they're fairly equivalent. I always tell people, if you need it, you go ahead and use it. I don't care if it says use it every 4 hours. If you need it more than every 4 hours, your asthma's out of control, and you need to go on to your next step on your asthma action plan. So there'll be some intervention once you're starting to use it more than every 4 hours.
And you bring up a very sticky point. There's the short-acting albuterols, which are the mainstay of rescue treatment for asthma. They're not a maintenance therapy. Some people say, well, I use my albuterol all the time because it helps me. And when they maybe use their inhaled steroid, they don't feel very good. But they can feel something like this. So they may not be compliant with it. And that really causes all kinds of problems. And then you add and you say, okay, the drug companies have made a long-acting albuterol. And there's been some studies out there that say that could actually be increase the death rate in patients with asthma. So you have to be careful when you use those longer acting medications. So.
Well, I would just say that altogether. The albuterol short-acting, long-acting alone, when used regularly, are trouble. That they should be rescue drugs, or they should be in combination with steroids.
And if you talk with your doctor, say, okay, I've used my albuterol once a week. That's fine. As opposed to I use my albuterol, well, it's just once a day. Well, that tells us it's more than 3 times a week, so we should be on a preventative program so we don't need to use it. We can breathe, we can run around, not worry about, gee whiz, am I going to have an asthma attack?
Right. So I think I would like everybody to remember that this is a rescue drug, and it's a warning that if you're using a lot of it, that you should be going to your maintenance drug. So let's talk about maintenance drugs. The steroid inhalers are the major things. Tell me about those.
As he's talked about, and I have too, that the swelling and the inflammation, the influx of white blood cells, inflammatory mediators, the treatment of asthma is controlling it and controlling that inflammation. If you don't have that inflammation, then you hopefully don't get bronchospasm and mucus plugging and wheezing. And so that's the mainstay. And I try to tell all my patients, if you were given a blood pressure medicine to take by Dr. Holm every day, you would assume that he was giving you the right medicine, and you would assume that every day your blood pressure is controlled. The same as with asthma, and people that need it, you should take that controller medicine every day. You may not notice that it makes you feel any different, but it is supposed to be controlling the inflammation. Sometimes we have to step therapy up by giving them a stronger dose of medication to control it and add additional things like the one caller that said they're on Singulair and a controller medication. But in general, that's the mainstay of treatment of asthma.
Yeah, I have to say, it's a steroid inhaler, isn't it? I mean,
steroid inhaler as a controller is the only intervention that shows a decrease in death rate from asthma.
It's the only intervention that decreases death
rates, right? And the more regular you are, the less people die from asthma.
The problem is it's so slow, long-acting, so slow to take effect. People don't know it. This one gives them immediate They know they feel it. Wow, I'm going to use this one, not the steroid, and it's the steroid that's the saving grace.
Right. And they say with studies with albuterol, the more patients with asthma use albuterol, the higher mortality rate. We don't know if it's complications due to drug toxicity or whether it be complications of untreated asthma. So if you're using your rescue inhaler more than a couple times a day routinely and it becomes escalated, you really need to seek help soon.
Get the controller medicine.
Old studies actually show that with albuterol, if you use it regularly 4 times a day, that there's a significant group of patients whose asthma will worsen. So they put people on 4 times a day versus just as needed, and then the 4 times a day could use as needed, and they do worse. There's a big group of patients that way.
Yeah. In fact, I've read one study where they would do a steroid carried with this, just the steroid and albuterol, And then they needed the albuterol. They'll use the albuterol until they got relief, until they got the steroid, and the relief went away, and they didn't need it. But we do that similarly with combination drugs called Advair or Dulera, or there's others. Symbicort. Yeah. So those three are combination long-acting albuterol and a steroid. Do you guys use those meds?
Yes, I use them quite frequently. If you want to get technical, Dulera and Advair are FDA approved for asthma, and Symbicort is FDA approved for COPD only. Advair is also FDA approved for COPD. But in my opinion, an inhaled steroid is an inhaled steroid is an inhaled steroid, and a long-acting beta agonist or bronchodilator is a long-acting bronchodilator. Right. So they just haven't done the studies and got the FDA approval yet. So
I mean, as an asthmatic as a kid, this saved my life. I mean, I could sleep. It allowed me to sleep, and I'd use it at night to sleep, and I did it. But I can tell you that for years, if you used it every night for sleep, you couldn't get to sleep without it. Until you get to a point where you go, no, I don't want to be dependent on a drug. And so it took me a while to wean myself off. And you get dependent on this albuterol. And so my point is that the steroid is your savior. Now, can I just prescribe a steroid alone for my patients?
Definitely. Meaning, do you mean just by itself and not a rescue?
Without the rescue, without combining it.
Well, I think you should have the rescue inhaler separate.
As a rescue.
As a rescue, and then just the plain inhaled steroid is the biggest thing.
Yeah.
And hopefully if you do the right job, and hopefully if you have the right patient and they respond appropriately, patients come to me and say, well, I haven't used that in 2 years, I think it's outdated. And so you just got to make sure that they have one on hand, because you never know that day that they could get into trouble.
Hit the trigger, that whatever it is. Lady walking across the farmyard, and her husband finds her collapsed in the middle of the farmyard. I mean, she was an asthmatic and she was wheezing a little bit, but she got into trouble, and he couldn't get her back. And by the time we intubated her in the emergency room, she was gone. And you know, it's just to see an asthmatic who was alive and fine yesterday and gone today. Here's a caller. Can exposure to black mold cause trouble breathing and phlegm in the throat?
I think mold of any type, lots of people have mold allergy, and it's especially the right size the mold spores are to get down into the bronchial tubes, and so they're a strong stimulus to keep things going. August, September, October, November is great mold season for triggering asthma, and then you catch your cold that's going around with all the kids on top of it. It's just a terrible combo.
Yeah. Comment? No. Okay. Caller has a nighttime cough, takes Advair and Singulair. I ask you quickly, we're running out of time. Would Singulair help? Should she would like to decrease her medication use. Would it be wise to stop taking the Singulair? How important is Singulair?
Singulair is an add-on drug. If you do the training that we've done and you look, there's a trigger, and then there's a ton of release. And that ton of release could be different molecules of different kinds. We talk about antihistamines like your Zyrtex, your Allegras, your Benadryls. They affect one part of that pathway. The Singulair affects another part of the pathway. So the multimodality treatment of asthma is to add different molecules that'll treat different pathways to try to decrease the inflammation.
I think the point here, though, is that you've got a patient who's got symptoms at night. Asthma's worse 3 in the morning, 4 in the morning, and that she's not controlled. And so she needs to go and get looked at to find out why she's still coughing. Is it asthma or is it something else?
Something else.
Yeah.
It's
not working well enough.
Is it reflux, that regurgitation in the middle of the night, those kind of things? So.
All right. Well, we'll be back right after this.
When you smoke, so does your baby. If you smoke while you're pregnant, you're putting deadly poisons into your blood. The same blood you share with your baby. It can damage baby's lungs, cause premature birth, underweight babies. Plus, babies of moms who smoke are up to 3 times more likely to die of SIDS. Please, quit before it's too late.
I remember my first asthma attack My family was traveling before the interstate was built in our old Chevy down 2-lane highways from DeSmet, South Dakota to the Ozarks of Missouri to visit relatives at Christmas. And my sister and I were exploring under the seat in the back, stirring up dust as we were discovering lost coins and toys. Not long after, I could not get my breath. What followed was years of asthma. I remember many nights lying awake, having trouble breathing until my doctor provided an adrenaline-like rescue inhaler. Wow. One puff of the rescue medicine meant airways opened and I could breathe, and so I could sleep. It changed my life. Asthma, like chronic bronchitis and emphysema, is a wheezing condition where airways are partially blocked or obstructed while trying to breathe out, trapping air and overexpanding the lungs. The cause of obstruction in asthma is from bronchial tube inflammation and results in twitchy, over-tightened, tiny muscles that surround bronchial tubes. Adrenaline-like medicines, also called beta agonists, are the rescue wonder drugs of asthma since they very quickly relax those twitchy muscles, giving immediate relief to an asthmatic. However, this does not touch the inflammation. And when beta agonists are used too often, bronchial muscles get used to the drug and develop resistance, and higher doses are required, and bronchial tubes and tiny muscles get even more irritable. Here is the rub. Studies have found increased asthma deaths occur when beta agonist inhalers are overused. What works so good can kill you. Whoa! But all is not lost. Steroid inhalers turn off the primary cause for asthma, inflammation. And when inhaled steroids are added, it breaks the cycle and even can protect the patient from danger resulting from beta agonists. Thus, clinicians should always prescribe steroid inhalers when asthma gets bad enough. Drug manufacturers are now putting together beta agonists with steroids into one inhaler, which give patients immediate relief provided by the beta agonist and get to the inflammatory bottom of the problem with steroids. Since beta agonists work so fast, they almost trick patients into using steroids that take time to work. Remember, beta agonists should only be used alone as an occasional rescue medicine. And if they're needed daily or too frequently, then the patient needs more anti-inflammatory steroids. So, stirring up dust in the back seat of the old Chevy does not have to make your life so miserable. We've got a comment from Winter. I quit smoking 1 month ago. How long for lungs to get back to normal? Smoked for 13 years. Tony?
It's a good question. Within a very short period of time, depending on who you are and what kind of exposure you have, your lung function will actually improve. And if there was any damage that was done to it from the tobacco smoke exposure, your lung function should decline at the same rate as somebody who never smoked.
That's great. One last comment, quick.
About that?
Yeah, well, about anything.
If you have asthma, stick with your program. Expect it to work. Have an action plan so you know what to do. And if it's not working, be sure to tell your doc.
Yeah.
All right, Tony?
No, call if you need help. That's the biggest issue.
This brings us to the end of our show this evening. I sincerely thank our studio guests and very good friends, Dr. Bubak and Dr. Hericks, for helping to answer all the questions from our audience tonight. Thank you for those questions. Science fiction author and professor of biochemistry at Boston University, Isaac Asimov, illuminated the subject when he said, "There's a single light of science, and to brighten it anywhere is to brighten it everywhere." Thank you both for joining us.
Thank you.
And until next time, stay healthy out there, people.
Funding for on-call television is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On-Call Television as it continues to open doors for important medical information.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding is provided by Dakota Care, the Brookings Health System, Dr. Mark Bubak and Dakota Allergy and Asthma, Dakota Dermatology, Aberdeen Asthma and Allergy, the Orthopedic Institute, and Swiftell Communications. Closed captioning for on-call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.